As 18-year-old basketball standout, the son of legendary basketball player LeBron James, collapsed suddenly yesterday while practicing on the campus of USC. Here's what we know tonight as we welcome Dr. Baxter Montgomery to the program. We know that a 911 call was made at 9:26 a.m. Paramedics responded, found Bronny James unconscious. Paramedics able to transport him to the hospital. Less than 24 hours later, goes from the ICU and now is hospitalized in stable condition. Quite the turnaround. The James family issuing the following statement yesterday while practicing. Bronny James suffered a cardiac arrest. Medical staff was able to treat him, take him to the hospital. He is now in stable condition. But beyond that, not many other details. So we are left to piece together the big question: what would cause an otherwise healthy young man's heart to stop? For that, we turn to the founder of Montgomery Heart and Wellness, Dr. Baxter Montgomery, cardiologist. My friend, welcome to the stream. Thank you so very much for taking the time tonight.
Thank you very much for having me, Chuck.
This is an interesting case, but one where I feel like we've heard about these incidents happening from time to time before. 18-year-old kid, otherwise healthy. As a cardiologist, how alarmed are you by an incident like this?
It's in many ways alarming because he's young and healthy, and so our thought process is that young, healthy individuals don't have these types of events. It's the general thought process is young individuals simply do not have cardiac events of any type, let alone a cardiac arrest. However, the facts are such that it is true that young athletes, albeit very healthy, can have cardiac arrest. In my, nearly 3 decades practicing as a cardiac electrophysiologist, I've, managed many individuals in their, teens, 20s, and 30s who suffer cardiac events, cardiac arrest being among them. And so it's certainly something that we see. It's not extremely common, but I would also say it's not extremely rare. It's one of those things that it's rare, but it's something that we have to be on the lookout for. And if you look at some of the data, there's some data that I may share with you that have looked at, cardiac arrests in young athletes in back, the 1980s, 1990s, up to the 2000s. It's identified more, and maybe that has a lot to do with the fact that we're identifying it more. But a cardiac arrest in a young person is something that we do see, and we have to be mindful of it. And it's something that we have to be ready to address in the medical community.
Yeah, and in fact, the LA Times reported that 75% of all sudden deaths that occur among NCAA athletes are directly attributable to a cardiac event. And then I know that you have some data that you'd like to present, but before we get to that, let me just share this with you. A 2016 study found that NCAA athletes have a 1 in 53,703 chance of sudden cardiac death. Although that number seems really high, 53,703, you got to figure that's about the number of NCAA athletes out there.
Yeah, and that it's one of those small numbers, but it's one of those things that you have to be alert for. Over the years, we've debated in the cardiology community whether or not we should do screening echoes or screening EKGs. And when you look at the numbers in terms of the incidence of these events, it's never panned out to where screening would be effective. However, you always have to ask that question again whenever, especially a high-profile individual suffers this event. We always go back to the drawing board and look at the numbers and determine whether or not we need to do more screening, et cetera. The question frequently comes up. I remember, back in the day when I was in my EP training, there were well-known basketball players, Reggie Lewis for the Celtics, and the player for Lamont Marymount, Hank Gathers, who actually had a cardiac arrest in a basketball game, and so he had a hypertrophic cardiomyopathy, and the percentage of individuals who have structural heart disease, hypertrophic cardiomyopathy is the number one cause in athletes, and historically it has been the number one cause. anomalous coronary artery disease. So if you have normally the coronary anatomy, you have a major branch, a coronary artery comes off the left side of the aorta, and a major branch comes off the right. And you can have certain kind of abnormalities in this coronary anatomy where you may have one come off of both sides. And the well-known basketball player Pistol Pete Maravich had an anomalous coronary artery where he had the right coronary artery came off the left. So both coronary, he had a single coronary artery coming off the left side, and this one went behind the pulmonary trunk and in front of the aorta. And he probably had a successful NBA career. He died suddenly at the age of 44 just playing pickup basketball. And it's when that coronary artery kinked. So you have these, rare abnormalities, whether it's cardiomyopathies or anomalous coronary artery disease that can cause cardiac death. And of course, there are other types of things like long QT syndrome, Brugada syndrome, et cetera. And we diagnose these individuals with these conditions, both young men and women. I've had a number of them in my clinical practice. I remember a young lady, I implanted her defibrillator, and it was just before her wedding. But she had long QT syndrome, and she brought her wedding dress in so I can make the defibrillator incision to be covered up by a wedding dress. So we see this on a fairly regular basis in our specialty. Again, it's not extremely rare, but I would say rare. But it's something that we perhaps over the years have seen more of.
And two more numbers that I want to throw at you from this 2016 study that really stood out to me. I would love to get your opinion. And I'm not sure that there is an answer here, but I would love to have you weigh in as a cardiologist. So that number we were talking about, that 53,000 plus risk of sudden cardiac death for NCAA athletes, well, you can about double that risk if the athlete was Black. It goes to 1 in 21,491. And then you can take that even further if the athlete is Black and a men's basketball player. That number goes from 1 in 53,703 to 1 in 8,978. That is an enormous jump. Why do you think that could be, Dr. Montgomery?
Well, certainly, again, looking at the hypertrophic cardiomyopathy, pathology, we see in Blacks in general have an increased amount of left ventricular hypertrophy for any given level of blood pressure. So if you think of, let's say somebody has, and when I say hypertrophy, a thickened heart muscle. So just think of someone who lifts weights, a bodybuilder having thick muscles. So think of those muscles being hypertrophy. So if you have a heart that has it becomes a thicker than normal heart muscle, that's a hypertrophied heart muscle. So if you have an individual hypertrophied heart muscle, then that heart muscle, regardless of the underlying cause, is an increased risk of cardiac arrest due to electrical abnormalities that can happen and other types of things that can happen in a thicker than normal heart muscle. So given that, Blacks have an increased amount of hypertrophy or thickening of the heart muscle for any given cause. Hypertrophic cardiomyopathy is sort of a genetic cause. It's a special kind of cause, but you have hypertrophy that's not necessarily due to hypertrophic cardiomyopathy. So that's one thing. So given the predisposition, and so I remember doing research at my cardiology fellowship, and myself and our lab and other labs showed that Blacks have an increase in the DD genotype, which is the genotype in the renin-angiotensin biochemical pathway that increases the amount of renin-angiotensin activity that predisposes to increasing heart muscle thickening. So just given that underlying physiology, that puts Black athletes at an increased chance of having a thickened heart muscle, whether it's at the spectrum of hypertrophic cardiomyopathy or any other types of hypertrophy, that has a greater denominator of individual with thickened heart muscle. So therefore, an increased risk could be explained by that.
Forgive the lay question here, but I think the average person hears thick muscle. They think nice, big, strong muscle. But in the case of the heart here, it doesn't sound like that's what the person wants.
That's correct. And thickening of the heart muscle, there's a pathological process to that. So when you think of thickening muscle, there's a lot of scarring that can go into that thickening process. And so you see a thick muscle, it's not all healthy muscle tissue. So there could be scarring that's a part of that process. And in the case of hypertrophic cardiomyopathy, you get disarray of the muscle fibers. And what happens is that the electrical circuitry, remember, the heart muscle has its own electrical circuitry. And so if you have scarring and distortion of the drywall, i.e., the muscular structure, then you can have distortion of the electrical circuitry, and that could predispose to electrical abnormalities, i.e., electrical cardiac arrest.
All right. I know that you put together a small presentation for us tonight, so why don't we go ahead and take a dive in that as we continue to kind of piece all of these puzzle pieces together here and try to figure a few things out.
Yeah, and I want to share this for most of our audience who are visual, and I won't kill you by PowerPoint, but just to give a little bit of organization to this. So, cause of cardiac arrest in the young, and this is how my thought process works. And just to let you know, in medicine, we like to go down this organized process of listing possibilities, and we call it a differential diagnosis. But you want to list all possibilities, even though they may seem extremely remote. You want to think about them and say, okay, why this, why not that? So we go around and we start with coronary or ischemic heart causes. So, what cause in a blood vessel of the heart that can contribute to this? Is it coronary heart disease? Is it a heart attack? Young people can have heart disease and heart attacks just like older people. It's not as common, but the prevalence is high enough the way you need to consider this. I mentioned anomalous coronary arteries. If you have where two branches should come off of separate sides of the aorta, but both of them come off one side, one can become kinked or distorted. And in just the right moment or the wrong moment, however you look at it, you can have a sudden occlusion of blood flow, and that can lead to cardiac arrest. Coronary artery vessel disease, inflammation arteries can cause a blood vessel to have an aneurysm or dissection. Atherosclerosis, arteriosclerosis, inflammation and plaque formation. Arteritis, that's a certain type of inflammation of the artery. Typically, that's due to some systemic inflammatory process, but arteritis is one of those things we think of. What are some of the non-coronary causes? So causes that are related to the heart that's not due to the arteries. Well, cardiomyopathies is high on the list. Now, cardio heart myopathies, abnormal or pathological process with the heart. Hypertrophic cardiomyopathy, I have that highlighted there. That's one of the more common causes. Dilated cardiomyopathy. There's a condition known as arrhythmogenic right ventricular dysplasia. We see it a little bit more in women, but men can have it. I implanted a defibrillator in a young pregnant lady who had arrhythmogenic right ventricular dysplasia, and she was having arrhythmias that threatened her life during pregnancy. And myocarditis, is one thing that we have to keep in mind, whether it's due to inflammation or some other cause. Then you have non-structural cause. Electrolyte disorders need to be considered, low potassium or the like. Typically when someone's resuscitated from a cardiac arrest, you're going to draw blood to evaluate for this. Channel disorders, Brugada syndrome. I've implanted defibrillators in individuals with Brugada syndrome. That's a sodium channel disorder that predisposes to sudden cardiac arrest. Long QT syndrome, another type of channel disorder, and familial sudden cardiac death. And there's some of these disorders where you just don't have an abnormal EKG and you can't put your finger on it. But once someone suffered a sudden cardiac arrest, then, oftentimes they are deemed to have a defibrillator implant. And we'll talk about the potential outcome. And of course, blunt trauma to the chest, commotio cordis. We're all familiar with that with Lamar Hamlin. And so that's certainly something that, you want to be mindful of, but certainly, you're going to see a history of blunt trauma to the chest for commotio cordis. Here's a study that Barry J. Marin looked at 1,866 deaths from 1980 to 2006. And although they saw increasing reported deaths the over time, a lot of it had to be due to the fact that, we became more aware of reporting cardiac death. But as I mentioned, hypertrophic cardiomyopathy, 36%. Coronary anomaly, 17%. These are the two more prominent structural causes. Commotio cordis is only about 3% here. And so you see that, yes, structural disease is very prominent. And individuals who are young, you want to think about hypertrophic cardiomyopathy, but also general risk factors. Young people are more often due to poor lifestyle to have coronary artery disease. You want to check for smoking, high blood pressure, high cholesterol, obesity. And this doesn't apply to young athletes, but I just wanted to give this laundry list. An inactive lifestyle. Again, these things don't apply to athletes typically for the most part, but it's something that you want to keep in the differential for anyone who suffers a cardiac arrest. So, clearly, it's a broad scope of things we want to consider. A young athlete like Bronny James, you got to think like about the structural heart conditions such as cardiomyopathy. I'm sure his cardiologists are running a battery of tests. He may get some kind of a coronary angiogram to look for anomalous coronary arteries. He'll likely get a cardiac MRI and a number of other blood tests to do a thorough evaluation as to the underlying cause. Typically, when someone has a cardiac arrest, you resuscitate them, they've recovered that event. So that's over and everything's fine. The issue now is, can there be another event? And if there can be another event, what do we need to do to prevent it? That's the issue right now.
And just generally speaking here, what is your opinion in terms of his prognosis, given the fact that he was moved out of ICU so rapidly? Does that lead you to believe that he's got a pretty bright future still ahead of him?
Well, yeah, so the future ahead of him is pretty bright from the standpoint of this event. He survived this event, and from the little I know, there's a very good chance that this event will not have any long-term effects. Now, again, I'm not a treating physician. I have no access to any medical information, but given the limited information we have, the outcome, I mean, they did an excellent job in treating him. He spent time in the ICU and was able to move out shortly. The key question now isn't so much as to what effects this event has had, because there's a good chance he has recovered fully from this event. The key question is, what was the cause?
Mm.
And what are we going to do now to prevent it from happening again? If the cause, and they're basically two basic lines of thought. There's either reversible cause that's effectively treated in and of itself, or there's a cause that's not necessarily reversible that cannot be treated. So, for example, if somebody has an electrolyte abnormality, the potassium is low, and maybe he was, not, drinking lots of water, not replacing electrolytes, that could be corrected. So basically, correct electrolytes. But if he has hypertrophic cardiomyopathy, that's a structural abnormality that can't be easily reversed. There's some treatments you can use for that. Or if he has what's called a channelopathy, Brugada syndrome, long QT syndrome, those conditions are not reversed. So those have to be treated with a defibrillator where the heart's monitored on a regular basis. So you're going to look, these are the types of things that you evaluate an individual for if they've survived a cardiac arrest.
And I'm curious, you just mentioned during your presentation there with the slides that there were a number of possibilities here. By and large, I mean, there were so many on there, but here on this channel and when you and I have chopped it up on the exam room, almost 99% of the time we circle back to diet and lifestyle factors. And again, without knowing specifics, is there any indication in any research that's been done that diet and lifestyle could have played a contributing role in this or any other cases beyond what was listed there? The obvious thing there, I said, where you had smoking and obesity and a few other things on that list.
Yeah, diet and lifestyle has a big impact, and it usually has a bigger impact in older individuals. Even in young individuals who are sedentary, it has a bigger impact. So clearly diet and lifestyle is something I always want to look at. And even in young, healthy athletes, I see young, healthy athletes from time to time. They come in and they may have an elevated cholesterol or blood pressure, whatever the case may be. And yes, diet has a big impact. We've done, even on the show, you'll see in clinical rounds, we present a situation with a 23-year-old who was very active, athletic, and he worked out, came in with chest pain and palpitations. We didn't see any life-threatening arrhythmias, but he had what we thought was possibly inflammation and some other things going on. And when you see that in clinical rounds, you'll see how we work through that. But in that individual, at that young age, even though he was thin, lean, healthy, when we did a nutritional intervention, it made all the difference in the world for him. So diet and lifestyle is always going to be at the foundation of anything you do. So I'm glad you pointed that out. And even though we list these things, whether you have hypertrophic cardiomyopathy or hypertrophy due to any other cause, I'm still going to go to that diet and lifestyle. Why? Because somebody has a thick hypertrophy heart. If you have a diet and lifestyle that contributes increase the inflammation in your blood system, that's going to make that heart more inflamed and potentiate more hypertrophy. And so lifestyle is always going to be the foundation of optimal health. And we clearly recommend people improve their diet and lifestyle as a foundation, regardless of what the underlying disease is or the underlying course of action. I've had individual electrolyte abnormalities or electrical abnormalities, and we can decrease arrhythmias with atrial fibrillation. I've seen decreased ventricular fibrillation with optimizing the diet. So that's always important.
All right. And if you don't mind, I'd like to wrap up with a question actually that comes to us from a viewer by the name of Mark, who's watching right now on YouTube. And look, we're talking about an 18-year-old kid. I mean, some people say 18, that's an adult, but 18 is still a baby in the grand scheme of things. So Mark is wondering what your opinion is on whether parents should be obtaining a lipid panel for their children annually, because you were just talking a little bit earlier about cholesterol.
It's a great question. There's a pediatrician friend and colleague of mine who talks about, the many kids she's seeing that have abnormal cholesterol. And, I think it's one of those things that you have to consider case by case, and perhaps they can talk to a pediatrician. If you know your kid has a very poor lifestyle, eating very poorly, then I would say absolutely yes. If your kid's very healthy, eating a healthy diet, then it may not be necessary.
All right, there you go. 18 years old. Bronny James suffering cardiac arrest, but now out of the ICU and recovery. And the final question, actually, Dr. Montgomery, is this. I mean, a lot of people are saying that Bronny James had a heart attack, but there is, in fact, a difference between cardiac arrest and a heart attack. Why don't we end with that? Could you explain the difference to us?
Yes, that's a great question. So, a heart attack, the classic cause of heart attack is where you have usually it's a sudden uh, um, termination of blood flow to a certain part of the heart muscle that results in heart muscle cell death. Now, typically that happens when a blood vessel obstructs. So you have a plaque that ruptures and it causes sudden clot formation that completely obstructs that blood vessel. So flow to that through that blood vessel stops immediately, and oxygen supply to all the muscle distal that's supplied by that branch of the artery is shut off immediately. So then cells start to die. That's the classic clinical heart attack. We call it acute myocardial infarction. Now, you can have subclinical heart attacks where you have closure of that artery to where the blood flow is not completely shut off, but so much blood supply is compromised to where you have a severe supply demand mismatch to where heart muscle cells die fairly rapidly, not maybe suddenly, but rapid demise and death of those heart cells. So that's a heart attack of itself due to supply demand mismatch. But a cardiac arrest is a sudden stopping of the heart. Now, most of the time when we see a cardiac arrest, it's due to an electrical storm. So the heart starts to fibrillate. So the heart normally beats in an organized fashion, but then you have an electrical circuit, short circuit, and so then the heart starts to fibrillate. And when the lower chambers fibrillate, then they no longer pump blood in a synchronized manner, and so blood flow stops immediately, and the person drops, say drops dead. So typically, when you see someone gets shocked with those paddles, they're resetting the electrical circuitry that's now. If it continues to fibrillate and there's no circulation to the brain, then you have brain death and eventually demise of the patient. So what you want to do when it's fibrillating, you want to put paddles on, you shock it. It's sort of like resetting the electrical circuitry to let the heart then comes back to normal. That's why we implant defibrillators, because the defibrillator has leads inside the heart. They can monitor electrical circuitry, and the defibrillator can read, and we can program it. Say, okay, the first 16 beats of electrical abnormality, you start to charge, the defibrillator charge within seconds. And it takes another look and says if the heart's still in this arrhythmia, it'll deliver a shock. So oftentimes, individuals with an implantable defibrillator, they can get a shock before they even pass out. I had one patient, he had a defibrillator, he started feeling weak and tired. And he checked his pulse and he felt his pulse for a second. And before he went out, before the defibrillator shocked him, he felt that he lost his pulse. And after 2 seconds of losing his pulse, he got a shock from his defibrillator. That's how fast defibrillators are. So cardiac arrest is usually an electrical cause. Now, non-electrical cause of cardiac arrest could be a large blood clot to the lungs. So that could cause it due to sudden shut off of blood flow from the lungs. You can have a massive heart attack where the heart muscle ruptures and you have massive bleeding and you die suddenly then. Or you can have a heart attack that causes an electrical storm. So a heart attack that causes an electrical storm can cause sudden cardiac death. So that's where you have sudden death secondary to a heart attack. That's because due to the short circuit, loss of blood flow and oxygen, the electrical circuitry is damaged, and then you have a cardiac arrest. But most of the time, a cardiac arrest is due to some primary electrical disorder, usually due to some electrical short circuitry that's in the heart muscle itself.
Yeah, and we'll end with this. I also read today where of these young kids who do suffer these cardiac events, if an automatic external defibrillator is used within the first minute, the chances of survival are 90%. That's
That's
a
right.
pretty extraordinary number.
That's right. The technology of AEDs has improved. I've worked with companies that have AID. There's a company that has an AED that is just released now. It has the battery is about the size of a cell phone battery, and they're made more readily available. Of course, you see them in airports, but AEDs are everywhere. It's important to have it in athletic facilities, and it's my understanding many athletic facilities have them around very handy, if not all, but many of them in our area use them. So it's important to have them handy and nearby.
All right. Well, Dr. Montgomery, thank you so very much for your time tonight as we try to piece together what really would make a young, otherwise healthy young man's heart stop. So many questions still to be answered, but I feel like we did get some semblance of an idea of what might be going on tonight. So thank you very much, Dr. Montgomery.
Thank you very much for having me.